facial recess and sinus tympani, and it can be frequently performed as a single stage surgery, which is a big condition in a developing country like India. This is a case done by me way back. I was very happy when I did this, and when I clicked this photo, I tagged it, I labeled it, I put it on Facebook. But now I am not happy when I do such a work. Disadvantages. The biggest disadvantage is periodic cleaning of the mastoid cavity, frequent infections, and the premise that you need to remove every mastoid hair cell, which is practically not feasible in a pneumatic mastoid. There is increased healing time. Healing results are worse due to shallow middle ear cleft, and this causes significant lifestyle changes in pediatric age group. There is cosmetic deformity due to wide metroplasty. This is a female operated by me. She might be happy, I am not happy when she ever visits me in OPD for her wax removal. This is a case, this is a photograph taken from internet. This is a badly done mastoid cavity. This is mine done. Again, patient visits every 3rd month, 4th month. Ridges is high, there are some mucosal cells lying buried. Frequent fungal infections are happening. This is the invalid I have created. This is another wide metoplasty. This one I revised. I don't have the poster photograph. This one I revised just for the sake of narrowing this bloody metoplasty. This one is a successful case. I did. He's a 14-year-old guy, visits me. I am happy, he is happy, but still I am not that happy. Canal wall up mastoidectomy. Advantage is, it preserves the normal anatomy of the ear canal. It avoids the risk of bowel problems, need of periodic cleaning. It reduces the healing time with better hearing results. Disadvantages. Anyone who is doing ear work will know, in a case of low tegmen, a poorly developed zygomatic root, there is limited exposure of epitympanum and posterior epitympanum, which will lead to blind and piecemeal removal of colostoma, which will lead to higher recitative rate, higher recurrence rate. And frequently surgery has to be staged, which is not possible in a country like India. In US, you can stage a 2nd stage surgery, you can do a 3rd stage surgery, but India, getting patient to table for the first time, you will have to complete the job. This is a narrow contracted mastoid. See how under the annulus we are working blindly. How the posterior tympanum, facial recess, sinus tympani exposure has been restricted. Another severely contracted mastoid. Intact canal wall approach and removing colostoma in this case will end up leaving colostoma, which will lead to recurrence. Soft wall reconstruction. It combines the best of the two worlds. Involves removal of canal wall by inside out technique for adequate exposure of critical areas to facilitate complete removal of colostoma sac in toto. Then reconstruction of the canal wall with Simba cartilage, leading to near normal anatomy and no mastoid cavity to worry about. It's like a November wedding up here in north. You want to, because the weather is little chilly, you want to have a hot gulab jamun. But it's little humid also, you want to have ice cream. Why not to have both of these two things in one bowl? Have gulab jamun with ice cream. It's about combining the canal wall down with canal wall up. Insert out drilling with minimal bone removal for excess of pathology. Sufficient gap between the medial lip of the cartilage and floor of adductus ad antrum. Preservation of mucous cell under the colostoma matrix, especially in the region of adductus ad antrum, so as to have a functioning mastoid hair cell system. Reconstruction of the posterior canal wall is with cartilage and soft tissue. This wall remains pliable and prevents any recurrence. The technique of soft wall reconstruction lends itself to relook surgery if needed. Philosophy of soft wall reconstruction. Philosophy is very simple. Minimal canal wall down bone removal for complete access, soft reconstruction of posterior canal wall, and direct communication of the mastoid air cell system with the middle ear via physiological antrum. There is some doubt. It will take some time. It's a reconstruction surgery. Actually, soft wall reconstruction takes less time than a canal wall down mastoidectomy with meatoplasty. As less time is spent on unnecessary bone removal, soft tissue work, more time is spent on reconstruction which is needed. There is no doubt the best way to clear a cholestoma is a canal wall down, because it gives you the exposure, it gives you the ability to do a bimanual removal of the cholestoma in toto. But leaving a cavity is no option. And best way to lower a canal wall down is inside out approach, akka anterior to posterior approach. And for soft wall reconstruction, inside out approach is must, because it leads to full exposure of cholestoma sac with minimalistic bone removal. Inside out approach, there are myths. It's technically demanding, it's unsafe, it's not for beginners. They are the bugger's myth. Actually, inside out approach is actually safer than outside in drilling. As throughout the drilling process, the surgeon is always drilling away from the critical structures rather than drilling towards them. It's actually about how are you trained. And I believe if a temporal bone dissection has to be done, a beginner should do an inside out. And if it does his temporal bone dissections inside out, he can approach his patient inside out. What is happening wrong is all temporal bone dissection courses, we are just creating more problem. Okay, there are issues with SWR. I don't know boss has those issues or not. I have those issues. It's a novel technique, but hearing recession as the middle ear height obtained is actually twice that of normal middle ear is a little issue. We are using vertical cartilage struts. Initial results are promising, but long-term viability of such long struts is to be seen. This was written almost a year back. Now I can say that struts do survive. I'm yet to see a case where strut has been absorbed. I have used struts up to the size of 1.5 centimeter. If they work, they work. If they don't work, they don't work. Long-term absorption is not an issue with the cartilage, given that the cartilage is autologous taken from ear, not from nose. My experience, it is yet to be updated, but a year back 98 cases have been done, 79 primary, 19 secondary cases, 3 residual perforations I had, maybe because of avascular necrosis. They were managed with fat plug technique. Initial audiological results with vertical strut ossiculoplasty were promising, with the average AB closure of around 25 decibel. And again I will say, it's about getting the best of the two worlds. You can have a normal ear like you have in a canal wall up surgery, and you can have exposure and complete removal of the disease like you have in a canal wall down surgery. It's just you have to change your perception. You have to change the way you see the glass. It's not half empty, it's half full. This was supposed to happen, the name was changed, and okay, everything. Thank you. Thank you everyone.